let's turn to Dr. Yusuke Shimakawa, who's a senior epidemiologist at the Institut Pasteur in Paris, who's done a great deal of work on hepatitis B vaccination and testing to improve prevention in African countries. And it's my pleasure to introduce him and I look forward to his remarks. Yusuke.
Hello, everyone. Thank you very much, John, for inviting me to talk about the NeoVac project. Do you see my slide?
Not.
Yep.
Yeah. So, yes, we do. Thank you.
Okay, thank you. So today I'm going to talk about the NeoVac project, neonatal vaccination against hepatitis B in Africa. A study funded by Total Foundation and sponsored by Institut Pasteur to evaluate the feasibility and the impact of hepatitis B booster dose vaccination through multidisciplinary approach, incorporating epidemiology, anthropology, and health economics in 3 French-speaking African countries in Senegal, Burkina Faso, and Madagascar. And we started the project in 2015. When we started the project, as a background data, all of these 3 countries have quite high prevalence of HBs antigen, according to the literatures. Senegal and Burkina Faso exceeding 11%, Madagascar 6.9%. All of these countries have already integrated infant hepatitis B vaccine starting at 6 weeks of life or 8 weeks of life, and introduced in 2005 in Senegal, 2006 in Burkina Faso, and 2002 in Madagascar. According to the WHO UNICEF, Hep B3 coverage was between 83 to 90%, but at that time, none of these countries have implemented hepatitis B booster dose vaccine. And that's why we started this project in these countries. But in Senegal, country started in 2016 booster dose vaccination, whilst 2 other countries have not yet introduced. And one of the, of course, key parameter for the successful implementation of booster dose vaccination is how much birth happens in healthcare facilities or attended by skilled health personnel. And this varies between 65 to 67% in Senegal, Burkina Faso at that time, whilst in Madagascar, it was less than 50%. So this is an initial plan of this project. We have 2 different phases. First phase is baseline formative phase, in order to develop a locally adapted, feasible, and sustainable community-based strategy. We don't know what it looks like, this community-based strategy, while we started this project. So we collect the data through epidemiological work package, such as percentage of women who visit antenatal care, percentage of women who deliver a child at health facility, or percentage of infants vaccinated within 24 hours for hepatitis B booster dose in case of Senegal, but for the rest of the countries, they have not integrated booster dose. Therefore, we look at 2 other vaccines, which are also recommended at birth, such as oral polio vaccine 0 or BCG. And anthropology work package is to develop insight into birth and early infancy concepts and practice, to evaluate local health system activities and capacities, and to characterize relationship between local populations and these health systems. And at the end of phase 1, we present all these data at local steering committee, which includes Ministry of Health, country office of UNICEF, WHO, patient association, and all healthcare workers on site. And we discussed the findings, and we defined together, first should be the intervention that should be tested in the next phase. And we saw that maybe it would be interesting to do home visit strategy, like out of cold chain vaccination delivery and so on. And then phase 2 is, as I mentioned, with the intervention which was defined in the phase 1 through multidisciplinary data collection system to assess the impact of the intervention in terms of the prevention of mother-to-child transmission through a cluster randomized control trial. And also through anthropological aspect, we can evaluate the acceptability of the intervention, and the health economics part can evaluate the cost and cost effectiveness of intervention. So this was the initial plan. So I'd like to start from Senegal. because, as I mentioned, in 2016, the country has opted to introduce booster vaccine. Therefore, we decided to evaluate what is the current situation rather than developing own intervention and assess its impact. So we conducted a study in 3 sites where there is health and demographic surveillance systems, HDSS, in which all the households within study area are regularly visited annually or biannually by a team of healthcare workers to collect the basic demographic data as well as vaccination data. And we also use this HDSS to estimate the proportion of infants who received the vaccine. And also we, with anthropologists, we conducted focus groups and individual interviews of local population as well as healthcare workers. And today I present the data from Mulomp and Bandafassi in Casamance and in Kédougou in Senegal. So first, epidemiological part, we focused on women who had a pregnancy outcome in the last 12 months. There was 388 in Bandafassi and 124 in Mulomp. These two areas are quite different because Mulomp, as you can see here, about 100, all the women made antenatal care visit at least once. And apart from one woman, everyone gave birth at the health center. And that's where there is a strong clinic supported by missionaries, and the sisters are really active for maintaining high activity for maternal and neonatal care. Whereas in Bandafassi, 87% of women visited at least one time antenatal care visit, and institutional birth rate was less than 50%, about 45%. And this is a coverage of vaccine at birth, BCG, polyoral first dose, and Hep B birth dose. So in Bandafassi, where institutional birth rate is less than 50%, finally, less than 80% of infants benefited all these vaccines. But in terms of timeliness, on the same day, within 24 hours, only 20% of infants had timely administration of birth dose vaccine. And in contrast, in Mulomp, where almost all women deliver a child at health facilities, of course, birth dose coverage as well as timeliness is good, but still there is a gap because it's 99% institutional birth rate. So if the implementation of timely administration birth dose at health facilities 100%, we should have 99% coverage, but there is still a gap. And anthropological study found quite many interesting findings. So in terms of child delivery at home, why in Bandafassi there are more than half of women who do not come to deliver a child at health facilities? First reason was access to health facilities. Of course, there are many women and families who do not have any means of vehicle or financial means to ensure travel. But interestingly, even those who have those financial means, women do not want to come to health facility when the contraction started, because having motorcycle or wagon and to be transferred with a contraction, it's very difficult, and they often call it double suffering. And also in Sere population, in some population, in some tribe, when women's worth is measured by her health, her ability to endure suffering in child delivery. So they have to show that they are strong enough to be able to deliver a child at home. So this kind of, there is a cultural barrier as well. And many women also perceive that there's a lack of hospitality in maternity service, and sometimes it's not hygienic, sometimes dark room, maternity room, and so on. In terms of vaccination, perception for vaccination was generally good. Generally, it's well accepted. And we also specifically asked about how about the vaccination at birth, what is the acceptability? But in fact, most of women who have given birth and whose infants benefited from a birth dose vaccine, women did not know that their babies received the vaccine. They were not informed. Because according to observation made by anthropologists, baby born at the maternity room, they are brought after the child delivery, they are brought to the next room where they get eye ointment, antibiotics, or birth dose, and they are brought back to women. So mothers are not informed, and mothers do not know that their babies got vaccine. So there is not much question of acceptability and so on, but we also asked whether if they are happy that their babies received the vaccine, and most of women say yes, it is very acceptable. We also, this is a bit beyond the scope of today's topic, but we also assessed awareness of hepatitis B, and 71% of lay population in this area had never heard of hepatitis B, but 68% recognized signs and symptoms of sequelae of chronic HBV infection and stage liver disease, such as jaundice, ascites, or cachexia. However, most of lay population relate these illness with occult origins, such as sorcery, poisoning, bad winds, and Satan. And also this is sometimes related with gendered social transgressions, such as men who developed liver cancer because that men saw a woman giving birth, or a woman who developed liver cancer, she saw a male circumcision ceremony. That's why she developed this kind of problem. So this is quite stigmatizing. And they also consider that this is not a hospital illness, but then the traditional healers should treat. Now let's move to Madagascar and Burkina Faso, which have not yet integrated hepatitis B birth dose vaccine in the EPI. So Madagascar, we studied Moramanga, a town like 6-7 hours drive from Antananarivo capital, where there are 8 health centers. So these health centers are scattered in the area, and none of these health centers, all of these health centers had refrigerator, but non-functioning at the time when we did this study. Therefore, all these health centers organized once weekly or once every 2 weeks vaccination session for all the children. So the day before there's this vaccination session, nurse working in this health center takes motorcycle and try to go to find the vaccine and bring back all the vaccine with a cool box. And the road is not very nice. This was not a rainy season, but the road was full of water and so on. So the situation was quite difficult place. Whereas in Dafra, Burkina Faso, which is a rural or semi-rural area next to the second city of Bobo-Dioulasso, this is also a rural area, but the situation was totally different. All the healthcare facilities had a refrigerator which was functioning. And also what was amazing is that some health centers which have a high volume of maternity activities, they had second refrigerator in the maternity room. And this is quite important because EPI refrigerator is very important. It's locked during weekend, during the night, to keep important vaccine. So whenever there is a childbirth during the night, during the weekend, maternity staff do not have access to this refrigerator. So that's why they put this second refrigerator where they usually put reagents for rapid diagnostic test of HIV or syphilis for antenatal care, but they also put oral polio vaccine so that they could administer immediately after birth. And they also made a registry specific for oral polio vaccine put in the maternity services. But this was only in some maternity service which had high volume. So this is the final result of the phase 1 in Madagascar and Burkina Faso. Madagascar, there was 1,000 women who had pregnancy outcome in the previous 12 months, whereas in Burkina Faso, there was 963 women. So in terms of institutional delivery, in Moramanga, there were only 38%, whereas in Dafra, it was 88%. Anthropological work package identified that in Madagascar, social norm is to deliver a child at home. And most of the women visit antenatal care, and that's where midwife tells them that, okay, your pregnancy is now going well. So this indicates to pregnant women that, oh, I can deliver a child at home. And only when there's some complication, they come to deliver a child at health facility. So norm is childbirth at home. And also there is distrust in healthcare facility, and also there are many different levels of obstacle in this context. In contrast, in Burkina Faso, before like 10 to 15 years ago, institutional birth rate in this study area was about 60%, but now it's improved up to 88%. It's very socially accepted because of the government put a lot of efforts to facilitate child delivery at health centers, and they provide free maternity care, neonatal care, and also they provide birth certificate, which also motivate women to come to deliver child at health facilities. In terms of percentage of neonates who received first dose of oral polio vaccine within 24 hours, in Madagascar, overall, only 3% of babies received oral polio within 24 hours. We stratify the analysis according to the place of birth. And for those who are born at health facilities, the rate was 13%. And this corresponds very well. This means that like 1 in 7 or 1 in 8 babies received oral polio vaccine at birth, because as I mentioned, most of health centers, vaccination session happens once every week. And therefore, when childbirth happened on that particular day, babies could benefit from oral polio vaccine. And for home birth vaccine, because mothers who give birth at home, often they have so-called confinement. They have a period where mother-child pair do not go out from home, avoid exposition to bad air or evil spirits outside home. So 1 to 4 weeks, they keep children and mothers at home. So there's not much, there's no custom of postnatal consultation. There's no, it's not implemented. In Burkina Faso, 54, overall 38% of neonates in this study area received polio vaccine at birth within 24 hours. By stratifying the place of birth, for those who were born at health facilities, more than half received polio vaccine within 24 hours. But this was not 100%. Because there was quite wide variation in practice, some health centers systematically provided oral polio vaccine, whereas the rest of the health facility did not do so. So there was variation. And even for those who are born at home, 21% received within 24 hours, because women bring children born at home on the same day or on the next day. So that's why this can be also another strategy. So now at the steering committee at the end of the phase 1, we discussed about some strategies that can be tested as part of the phase 2. And of course, outreach home visit strategy, this can be, this might be interesting. So we discussed. In Madagascar, we saw that this is highly relevant because 62% of childbirth occurs at home. However, generally, there is a severe shortage of human resources in primary care. Therefore, none of the midwife or nurse can leave their health facility just to provide birth dose through outreach home visit strategy for one single baby. And also, we discussed a lot in terms of task shifting to community health workers, but this was refused at that time in 2017. First by Ministry of Health. Ministry of Health says that community health workers, they are there just for promotion of health in the community. They are not there to make immunization action, medical act. And also local population through anthropological work, this was highly denied because, as I mentioned, there's this custom of confinement, and people say that even this was given by former healthcare workers. They do not want that their babies to have injection because they are so much infants as neonatal babies so vulnerable to have such injection. And community health workers, they are the farmers working next to them. They are just mobilized for the health promotion. So local population also denied. And in Burkina Faso, so that's why in Madagascar, after the steering committee discussion with the Ministry of Health and so on, we decided to not test any intervention. We say that we need to still try to understand how hepatitis B disease is perceived in the community through anthropological study, and also what is a disease burden in this context. And in Burkina Faso, which might be less relevant in terms of outreach home visit strategy because 12% of infants are born at home, but still this can potentially increase the coverage of timely burst dose vaccine. However, as a steering committee, people say that there has been enormous efforts put by the government to promote institutional delivery. Therefore, if now you start to say that, okay, recommendation is that you come to deliver child at health facilities, but in case you cannot, we are happy to send someone to give hepatitis B vaccine at home. This is a mixed signal to the population, which confuse the population. Therefore, we saw that outreach home visit strategy was not relevant in this specific context. But in Burkina Faso, we observed high rate of institutional delivery. Therefore, we consider that administering Hep B burst dose in maternity service should result in high coverage of timely burst dose vaccine. Therefore, we decided to evaluate this as a phase 2 in Burkina Faso. But committee also questioned to what extent the addition of hepatitis burst dose would further prevent infant hepatitis B infection when there have been already 3 doses of pentavalent vaccine have been implemented. And indeed, so this is the efficacy of hepatitis B burst dose schema. So in Asia, I stratified according to maternal e antigen status in terms of risk of mother-to-child transmission. Without any intervention, as John already presented, the risk of mother-to-child transmission is like 70 to 90% from e antigen positive mothers and 5 to 30% from e antigen negative mothers. And the literature clearly shows that there is an efficacy of burst dose vaccine, 70 to 80% for e antigen positive mothers, in comparison with without any prophylaxis, without nothing. But this is not really the question actually in African context, where there have been already infant vaccination starting at 6 weeks or 8 weeks of life. So the question should be, in comparison with the vaccine starting at 6 to 8 weeks of life, what is the vaccine efficacy? And indeed, there's not much data from Asia. And what is the data in Africa? So there's one single study in Cote d'Ivoire by ECRA, which assessed vaccine starting at 6 weeks compared to vaccine starting at birth. And they found that among those who are born to e antigen positive mothers, the risk of mother-to-child transmission was 58% with vaccine starting at 6 weeks and 37% with birth dose followed by infant vaccination. So this indicates vaccine efficacy of maybe 36% only. And the recent study in North Cameroon by François Fabiani also found that the risk of mother-to-child transmission from e antigen positive mothers with the presence of a timely burst dose is 28%. So the gains that we can have with Hep B burst dose may not be, I don't know, but may not be so much convincing. So that's why for the phase 2 of the NEOVAC, with the steering committee, we decided to evaluate the impact of incorporating the monovalent hepatitis B burst dose into the infant immunization program in real-life field condition in Burkina Faso, where the hepatitis B vaccination is currently scheduled at 8, 12, 16 weeks of life through a step-wise cluster randomized control trial. So the study was started in October last year. And we study in an area where there are 24 health centers. At the beginning of the study, none of these 24 health centers provide burst dose vaccine, only a pentavalent vaccine at 8, 12, 16 weeks of the day are scheduled. And 3 weeks after the start of the project, we randomly select the first health center which starts providing burst dose. And that health center continue to give burst dose and pentavalent vaccines throughout the study period. And then 3 weeks after the first one started, we randomly select the second health center, which starts implementing boost dose. And we repeat this every three weeks until all 24 health centers implementing boost dose vaccine. And during that period, this study design generated 2 groups of infants. One is infants who were born before their health center started providing boost dose vaccine and received only pentavalent vaccine. Therefore, they can be considered as a control group. And there is another group of infants who were born after his health center started providing boost dose vaccine. Therefore, we can consider this as an intervention group. And we plan to compare at the age of 9 months when they come to receive measles vaccine and yellow fever vaccine. We evaluate HBs antigen positivity for mother-child pairs to evaluate the mother-to-child transmission risk. So the study is currently ongoing in Do and Dafra district. And this is my final, so this is towards my end of the talk. So we also conduct, this is also slightly beyond the scope of today's topic, but we also conduct ancillary study embedded in this Neovac study called PredictB, which is funded by Gilead and Abbott. And we evaluate using this platform of mother-child cell survey. We evaluate inexpensive alternative markers to identify high-risk mothers and to predict mother-to-child transmission. Because as you know, hepatitis B, HBV DNA quantification using real-time PCR is really costly, and this has been considered as an obstacle to select high-risk women. Therefore, here we assess the accuracy of hepatitis B E antigen, as well as hepatitis B correlated antigen, and also loop-mediated isothermal amplification assay, which is a simplified method of nucleic acid testing, which have been already, accuracy has been suggested in other contexts, such as Prolifica project with Dr. Modelemore in the Gambia, but we assess this again in this context. So the conclusion is, according to our experience, barrier to timely administration boost dose vaccine, of course, first barrier is home birth. But there's also still gap for children born at health facility. Health facility birth children, they do not all benefit from timely administration of boost dose, and there should be some efforts to be done at this context. And as we can see here today, there is a considerable variation in obstacles and facilitators between countries, but even within the country, there is a lot of variation. Therefore, one size does not fit all. And in our specific context, outreach home visit strategy seems to not be the best solution. And this is also a little bit beyond the scope of today's talk, but I think we can also think about consideration for other strategy. Particularly now there's this WHO guidelines for maternal screening and peripartum antiviral prophylaxis for high-risk mothers. This strategy combined with hepatitis B boost dose, this will be going to evaluated in North Cameroon and in some other contexts as well. This can be interesting. And even in some contexts where child delivery at health facility is very difficult, maybe peripartum antiviral prophylaxis alone could be also a strategy in some special areas. Thank you very much. And I would like to thank all the investigators and collaborators of the Neovac project. Thank you.
Thank you very much. Very informative presentation.